So lateral chest x-ray, just basic housekeeping on lateral chest x-ray, the things that you know, we're gonna run through real quick, just basic positioning. Mid-coronal plane, mid-sagittal plane with lateral. Mid-coronal plane is gonna be perpendicular to the image receptor. Mid-sagittal plane is gonna be parallel. Make sure you get your arms up. Moment of truth. First year student, as a first year student, anybody ever forget to raise the arms for a lateral chest x-ray? Yeah, yeah, okay. I got one honest person, I did it.
I did it in the practicum.
It was in practicum. Nice, nice. Mine was actually in clinicals, and at the time, you know, the texts were not real good about, you know, telling you what you did wrong. They just said you gotta go reshoot that. Guess what I did?
Left him?
Did the exact same thing second time. I was like, God. You know what was bad is it was two students. Two first-year students just blasted this patient on a lateral chest x-ray 3 times, 2 of which with a humorous way. You know, when I tell y'all you can't do something that I hadn't already done, you know, don't be embarrassed. I'm being serious. I'm a hard learner. I make a mistake, I'm gonna make it at least twice. So, but thank you for your honesty. Remember on your lateral chest x-rays, what we want to get is that posterior costophrenic angle, and you don't really see the apex of the lung all that much. So on your lateral chest x-rays, if you're getting close to and clipping that posterior costophrenic angle, you might want to lower, even though the textbook says, and the testing is going to say that you centered T7, you might want to lower it just a little bit, maybe down to T8, just a practical tip for in clinicals. And then I think Merrill's has kind of made a switch to inspiration, you know, inspiration, expiration, inspiration for lateral chest x-ray as well. In a practical sense, that, you know, single inspiration, the purpose for the 2 inspirations for the PA is to get the lung fully expanded. But on the lateral chest x-ray, you've kind of done that stretching, right? So the single inspiration for the most part is adequate. So you want to see from the apex to the costophrenic angles, you want to see the anterior and posterior surfaces, so you want to see that depth. Remembering that on your lateral chest x-ray, what we'll get is the completion of a 3-dimensional image. We only see 2 dimensions on the PA or the AP. And so the lateral provides us that depth perception. Also remembering that our lobes, you know, in our right lung, we've got 2 lobes, left lung, we've got 3, and they don't just go upper, middle, lower, that the fissures are at a pretty steep angle. So without that lateral, you don't get that depth perception to get an idea as to where that, you know, the mass may be. I'm gonna bring this one up. I'm not gonna turn those off. I'm gonna bring this up and kind of draw this out. So on lateral chest x-ray, you know, you've got posterior costophrenic angle, and then your fissures may look like that. So on your PA chest x-ray, go ahead and draw that out. Let's say we're looking at the right lung, and you've got a mass right there. Looking at that, you know, just that all by itself, knowing that you've got 3 lobes, upper, middle, and lower, you know, forgetting I've drawn this at all, where would you call that mass? Middle lobe, right? It looks like middle lobe. But then you've superimposed this on that, and could it not be right here? Could be posterior lobe, could be middle lobe, could be inferior lobe, right? So the lateral gives you that 3-dimensional perspective. There was a trend for a while. I went to a seminar where a radiologist spoke, and a radiologist said that they don't even do lateral chest x-rays anymore. I think there might have been a move at one time to get away from doing lateral chest x-rays. I think they're very valuable. They're not as valuable, don't give you as much information as PA, but in that context, you know, it's absolutely essential to know where that is. So a couple of things also, and forgive me if I clear my throat a lot. I'm getting over a respiratory thing. So the things that we tend to overlook a little bit, or we settle for in some of your older patients, is elevation of the arms. Sometimes your patients have a hard time getting their arms up above their heads, and they reach straight out in front of them, right? So you lower the arm bar, and the patient reaches straight out in front of them. Problem with that is you're going to have soft tissue over the apex of the lungs. Now, I know I just said you don't really see the apex all that well on a lateral, but you do see it to a degree. You can pull that shot if you want to. And with the arms straight out in front of them, especially in your older patients where the skin starts to sag a little bit, it's going to cast a pretty good artifact over the apex of the lungs. So you need to get them up as high as possible. Some of your patients are not going to be able to accomplish that, and you're just going to have to do what you can do. So rotation, with rotation, what's the rule of thumb for rotation? So a lateral chest X-ray patient, you got obvious rotation, posterior ribs not superimposed. What do? What's your rule of thumb? Do I repeat this? Do I not repeat this? How much rotation is adequate? Huh? A half an inch is textbook, right? Half an inch is not much. Not much at all. What do? Bingo. 2 fingers. Okay? That's about a half, 3/4 of an inch probably. All right? So, half an inch is very little, right? And if it's a difficult patient, what fingers do you use? It's a PA. This is not rotated lateral. It's not, so you settle, right? But half an inch rotation is textbook positioning. 2 fingers is really a bit much. But is that a reason to repeat every lateral that you ever shoot? And the answer is no. Again, depending on what the patient's condition is, if you've got a patient that's very difficult and they're a danger to sit up, then obviously it's better to have a little bit of rotation, even a little bit of rotation beyond the acceptable rotation, than to have the patient hit the floor. Now you got a skull series, and you got a shoulder, and you got a hip, and all this other stuff that you can do, right? So when we're talking about rotation, what we're talking about is our coronal plane is no longer going to be perpendicular to the image receptor. So as we're looking at rotation, what we've got to do is we have to assess which lung is anterior and which lung is posterior to determine which way to re-rotate the patient or rotate the patient. The first thing that you want to do is you want to refer back to your PA and look and see if the patient has scoliosis, because if the patient has scoliosis, you're not getting rid of the rotation of the lateral. You just got to live with it. Because with scoliosis, not only do you get that lateral bending, but you also get a little bit of rotation there as well. So you cannot overcome the rotation on a lateral chest X-ray if a patient has scoliosis. So you want the diaphragm superimposed. A couple of things on that is that, from your basic anatomy, that the right diaphragm is higher than the left diaphragm, but since it's elevated and away from the image receptor, and because you're using a divergent central ray that's coming down at an angle, have you ever noticed that they're almost perfectly superimposed on a good lateral on a healthy person? They're almost perfectly superimposed. That's why, is because the divergent central ray pushes that naturally elevated right diaphragm directly down on top of the left diaphragm. So they're almost perfectly superimposed. So then it becomes difficult, if the right diaphragm was elevated, as it is in your normal anatomy, then it would be easy to determine which one is, which way you're rotated. If the high diaphragm is anterior, then you're rotated towards the image receptor, as opposed to backwards. Right, as opposed to being 2AP rotated, backwards, then that high diaphragm would be posterior. So we can't use that. But what do you always have directly below your diaphragm that you could use for analysis of rotation?
Stomach.
Gastric bubble. Bingo, gastric bubble. So your gastric bubble, unless you have a person who has, all their organs flipped, situs inversus, then your gastric bubble is always going to be underneath the left diaphragm. So then you just look for the gastric bubble. Coincidentally enough, I've got a stomach here. So what we do is you're looking at the diaphragms. Diaphragms should be, and ignore the position of my hands because I'm dealing with a divergent central ray here as well. So your diaphragm should be fairly well superimposed, right? So if we've got rotation, then you see not just the rotation of the vertebra, but you also see the rotation of the diaphragms. The two diaphragms are not going to be superimposed, perfectly superimposed. So what you're going to look for is that gastric bubble. So if the patient is rotated where their right lung is anterior to the left lung, that's going to put the gastric bubble behind, right? It's going to put it posterior. And what that means is that you need to advance the left side of the patient's chest, pull the right side back some, right? So if the gastric bubble is anterior, then what that's going to mean is that you've rotated with the left side anterior. Okay, so gastric bubble. Also, while I'm thinking about it, we're going to talk about mid-sagittal plane tilt. All right, so mid-sagittal plane should be parallel to the image receptor, right? And the coronal plane should be perpendicular to the image receptor. So in those cases, then you've got the diaphragm superimposed. And if you have a situation where you've got a guy, let's say, and it's most of the time this is a problem with men who have broad shoulders and narrow hips, and you tell them, I want you to put your side up against this image receptor, what are they going to do? That, right? So what happens with the right lung? It's going to go down, the left lung is going to go up, so you're going to have separation of those diaphragms. So you can also use a gastric bubble to determine that. So if I'm like so, then what that's going to do is going to elevate my left diaphragm. So if the gastric bubble is high and the right diaphragm is low, then you've mispositioned in this way, as opposed to if a patient has broad hips and narrow shoulders and you tell them the same thing, they're going to have a tendency to lean into it. In that case, that diaphragm, the left diaphragm in the gastric bubble is going to be very low, as opposed to the right diaphragm is going to be elevated. Okay? So that's lateral chest x-ray in just a couple of minutes. So one other thing that we have to be concerned with is that sometimes you get a patient in the department where they're on a stretcher, you did an AP chest x-ray on them, but they want a lateral. Again, maybe there's a pathology, they're trying to figure out where that pathology is, which lobe it's in. So you're going to do a seated lateral chest x-ray. And the textbook warns against or cautions against foreshortening of the anterior lobe of the lung. It's not really foreshortening. Foreshortening has to do with mispositioning of the anatomy compared to the image receptor and the central ray, right? But if you have a patient, and let's just be honest, most of the patients that we get are not going to be healthy, and the older we get, we add pounds, right? You're going to find that out. So you take a patient, you set them straight up, then what happens and what can happen is that stomach mashes into the tops of the thighs, and mashing into the tops of the thighs, you've got, everything in your abdomen is fluid based, and fluid does not compress. That's the basis for hydraulics. Hydraulic jacks, the way they work is just forcing fluid. And if you can't stop the fluid, it's going to move something, right? So in this case, you mash the stomach, and the stomach in turn mashes upwards because it can't mash downwards into the thighs. It mashes upwards and it compresses that anterior lobe. So the patient can't get a big deep breath, right? And that anterior lobe is a little bit compressed. It's not really foreshortened. Just understand that that's terminology in the book. They call it foreshortening. It's not really foreshortening, it's compression. So in your seated lateral chest x-rays, the better positioning would be, even though it's, gonna look a little bit odd on the image receptor, most of your image receptors are gonna be 17 by 17 or 16 by 16, right? Gone are the days of strictly 14 by 17 image receptors. So you've got a little bit of leeway, and what you can do is, instead of setting the patient up at a 90-degree angle, do two things. One is separate their thighs so that their stomach's not, mashing off at their thighs. That's number one. Number two, lean them back just a little bit. You can turn your collimator housing and you can maintain good collimation by leaning them back just a little bit. It'll decompress that anterior lobe, okay? So those are really the main lateral chest x-ray things that you gotta watch for is rotation. You got, coronal plane mispositioning where it's not perpendicular. You got rotation anterior to posterior. Leaning is mid-sagittal plane or sagittal plane positioning. And the complications with those, and then you've got the compression on the seated lateral. So lateral chest x-ray should look like that, and it's pretty close to, you got a little bit of separation of the posterior ribs there. Is that a half an inch? That's pretty close to it. Would you repeat that?
No.
You need a beating if you try to repeat that. Because chances are you're gonna go back into the room and you're gonna shoot a worse lateral chest x-ray than that. That's pretty good, right? This rotation is not perfect, but there's no saying the enemy of good is better, right? You try to go in and reshoot that to make it perfect, and you're probably gonna shoot one worse than that. So, the two-finger thing is probably extreme, right? But at the other extreme, that half an inch is probably a little out of line as well. Okay, so good positioning, arms elevated. Watch your patient real well, though. Sometimes they're holding on to that grab bar, and they kind of pull themselves out of the collimated field, So just watch positioning, watch your patient before you make your exposure to make sure that they're still in the lighted field. So again, purpose for the lateral, where is all this stuff? Well, I don't know. What is all this stuff? Also don't know. Could it be cancer? Yeah, probably could be. Could it be, just, I don't know, start a pneumonia? Could be, I don't know. But where is it? Don't know. So we do lateral again. So we've got this little issue up here. Probably from the PA you can tell that that's going to be in the upper lobe, but certainly on the lateral between, the AP and the lateral, or the PA and the lateral, we can make that distinction pretty well. Patient's got a broken humerus too, shoulder. So more, all this stuff is in the PowerPoints online. So just different pathologies. Middle lobe syndrome. I can't correct that. I've got it open in my office. I can't even pronounce that. It should be syndrome. All right. So on the lateral, what we want to see is apex to the costophrenic angles. We want no overlap of the soft tissue. We want to see from front to back, no rotation. The diaphragm superimposed. Proper collimation, and probably of all of the positioning errors that I see in images online is collimation is, we've kind of, I think the large image receptor sizes that we're using now has gotten us a little bit lax on collimation. Collimate to the skin line or no more than a half an inch past the skin line. Don't include things that don't need to be included. I see lateral chest x-rays where they've got almost all the way down to the iliac crest. You're not even trying, right? So we talked about all that. Determining rotation, we talked about all that. So the textbook, and I apologize for this image, some of the images don't magnify well and they get a little bit fuzzy. And I just wanted to point this out that the positioning, one of the positioning things that the textbook mentions is position of the heart. Personally, I've not been able to really develop an eye for determining rotation according to the positioning of the heart, all right? But they do say that if you're rotated anteriorly, then the shadow of the heart's gonna extend past the sternum and past the ribs, as opposed to the left lung being posterior. It is not. Okay, so if you can visualize that on your x-rays, great. If not, use gastric bubble, which I find to be so much better. So that's the same lateral chest x-ray. Scoliosis, you're just not gonna be able to fix it. Don't try, just do the best you can and submit with your PA. All right, so this we have true rotation, and according to our 2-finger rule, this is probably a, air quote, good lateral chest x-ray. It's really kind of not. We've got a number of things going on here. What positioning errors do you see?
Right side is anterior.
Okay, the right, very good. Right side is anterior. There's gastric bubble, which would indicate that this is the left diaphragm, so that's right side anterior. Is there anything else?
Carotid.
Is that?
They're leaning forward.
Maybe. It looks like they might be a little bit on the kyphotic side. They may be kind of, notice the position of the humerus, okay, and we've got soft tissue there. So what you may have is, because the arms are straight out in front of the patient, they may be hanging on to that grab bar, and they may just kind of be leaning back just a little bit, or it just may be their anatomy. I don't really see any obvious compression fractures. Maybe on the screen over there, I don't know, I'll have to take a look at it. But we do see some narrowing of the disc spaces, so it very well could be the patient's anatomy, right? They may just be a little bit kyphotic. It's awfully gray, I can't really make out the vertebra that well over here either, okay? So what about on this one? What do you see?
It's the right side lower to the left.
Okay, so we see separate, unfortunately, we don't see all, the gastric bubble. This is the one person who doesn't burp, I guess, I don't know. But we see vertical separation of the diaphragms, which is very good. Whether we're leaning towards or leaning away, I don't know. I'd have to see the specific patient to be sure. What's interesting about this one, I wonder if we don't have some degree of scoliosis going on with this, is that the diaphragms seem to parallel each other, and yet we've got rotation. So do we have a little bit of scoliosis with this patient? I don't know. Without seeing the PA, it's difficult to tell, but we do definitely have some vertical separation, which could be caused by scoliosis, or it could be caused by mid-sagittal plane positioning, mispositioning, mid-sagittal plane, leaning towards or away from the image receptor. How about that? Yeah, the arms aren't even parallel. They're it's almost down to their sides. So yeah, surely you could get the arms up higher than that. All right, so just more the same. Okay, so if you have to do a right lateral, and in every textbook, they'll make the point of saying that left lateral is the preferred lateral for chest x-ray, unless there's a specific pathology, and then in the right side that you would want to increase sharpness or recorded detail, then you'd do right lateral. So potentially right lateral here. Now the reason I say that is it's facing in traditionally the wrong direction, but plus we've got separation of the diaphragms, and the gastric bubble is up inside the thoracic cavity, right? So it's above the left diaphragm. So if you shoot a right lateral, you're always going to have that separation if you shoot a left lateral, they should be pretty close to on top of each other. So in your assessment, if you have to shoot a right lateral, keep that in mind, that the separation between the two diaphragms is gonna be exaggerated, because now your low lobe is gonna be even lower, right? Which is counterintuitive. Let me take that back. So if we do a left lateral, then where that gastric bubble should be is way down here. So it's not a right lateral. It's not a right lateral. And have a time to mentally process this because I was down on the left. So what might we have going on there? Well, it could be mid-sagittal plane tilt. We could have a situation where we've got, the one diaphragm locked, right? So diaphragmatic paralysis of some sort, be it because of obstruction or whatever. So again, non-superimposed, our posterior ribs are superimposed, so we've got a tilt or we've got something going on. But if you look at the PA projection, what do you see here? Does that look normal? Which diaphragm should be lower? Left or right?
The left.
Which one is lower? Right. So we've got something going on with that diaphragm causing it to be elevated. And that's what's causing our separation. So, and the long and short of that is that there's probably no positioning error there. It's just that patient's anatomy. Okay. That's just a mess, almost no inspiratory effort in that case. We don't really see a whole lot of rotation, but our lung is completely compressed there, so probably shot on exhalation. Seated lateral chest X-ray, you see, let me back up to a normal lateral. You see where you've actually got an anterior costophrenic angle that comes down to a point here, as opposed to here. You don't have that. That's your seated lateral where you've got the patient upright to the point where you've got compression of that anterior lobe. Okay. And then pathologies, right side pleural effusion. We talked about that last week. A pleural effusion, you're going to diagnose that more specifically with cubitus. We got the tilt, rotation, and that is just, that's unacceptable, really. The collimated field shouldn't extend that far down, almost to the iliac crest. Hypersthenic patients sometimes provide I'm not even going to say hypersthenic patients, but rather barrel-chested patients. Sometimes it's difficult to get on the image receptor because of the thickness of the chest. It's difficult to get them on there. I remember this one in they just couldn't fit this guy on a chest X-ray or on an image receptor for lateral chest X-ray. It's really pretty rare, but it does happen. All right. So when I took the color out of the slides, it kind of reconfigured things. So I just had to deal with that. So with AP abdomen, marker placement, where do you put your marker? I see some pointing down in the hip. Yeah. I've seen people routinely want to put it high. Problem with that is you're going to put it in the liver potentially. So hip is a better place to put it. So marker placement, generally in the hip. Again, our Bucky slots have gotten so thin. I don't like the trend of putting the marker directly on the patient's anatomy, but at the same time, do you spend $20 a week buying new markers? And the answer is no, you don't. So, I kind of understand it. I don't like it, but kinda understand it. So contrast and density, what we wanna be able to visualize are psoas muscles, gas patterns, we wanna see the inferior border of the liver if possible. We wanna be able to see the kidneys, you should be able to see the kidneys. Liver sometimes is difficult, but we're gonna use the bony structures for assessment for any kind of rotation or anything like that. So artifacts, zippers, even if the patient has a plastic zipper, like sweatpants zipper, that toggle, the handle that zips it up is gonna be metal, needs to get out of the way. Snaps need to get out of the way. Bras, even if they're sports bras, sometimes they'll cast an artifact. So if they can pull those up and get them out of the way, they don't have to take them all the way off. But if you're doing an upright abdomen, it probably needs to come off. So your KVP, what are y'all shooting KUBs with nowadays? 85? 80 still? Yeah. So save you the physics lecture and the trip down memory lane here. So grid use, a couple of things on that. One is, we tend to get locked into the idea that if we're shooting an abdomen, we have to have a grid, right? Because we're shooting through almost all water type structures, and generally we're pretty thick, right? But what if you have a pediatric patient? What if you're shooting for a UVC line? It's a neonate, and they just put they don't stick a neonatal patient if they're doing a central line. They just put it in the umbilical vein, right? So do you need a grid for this kid that's that thick? And the answer is no, you don't. What if you're up on the floor and somehow or another you forgot your grid and you're shooting an abdomen for a feeding tube? What are you looking for on a feeding tube specifically? How do you position for feeding tube placement?
Low chest X-ray.
So low chest X-ray, exactly. What are you looking for specifically?
Make sure to.
Mobile.
You're looking to see if it's below the bifurcation, right? So make sure it's not in the right main stem bronchus, right? So are you making diagnoses of kidney stones, gallstones, or any kind of pathologies in the abdomen? The answer is no. So is it worth it to go all the way back down to the X-ray department to get a grid to come back up to shoot a feeding tube placement? The answer is no. Okay, so there are times that you need to go get that grid. If your machine has, virtual grid, great. Don't even worry about it. But there are times that you can shoot without any kind of grid whatsoever. So grid use when it's appropriate, which is most of the time, and there are cases where it's optional. If you're phototiming, just know your equipment. Could be the outer two cells, could be the center cell, could be all three cells. Respiration, textbook and test answer is going to be on expiration, and the reason for that is to elevate the diaphragm so that the contents of the abdomen kind of spread out, right? So that it's not all bunched up. Whenever you breathe in, the diaphragm lowers and it pushes everything out front, right? So expiration is your textbook answer. What's your routine in the hospital? No routine? Just let it rip?
Just don't move.
Just don't move? Yeah. Some radiologists prefer inspiration, and that way you're more likely to be able to see the entire contents of the abdomen. They're the ones reading the images, so follow your hospital, your doctor's protocol. But for testing purposes, it's expiration. And hold, expiration and hold, make sure that there's no motion. So with your KUB, we're gonna assess KUB kind of like what we looked at in our freshman year positioning of the pelvis. We're gonna look at the pelvis, we're gonna look at the vertebra to determine rotation. All right, so we're gonna, just like in the chest X-ray in the KUB, we've got coronal plane, placement, we got mid-sagittal plane placement, we got assessment of the pelvis, we got assessment of the vertebra, and then we wanna make sure the arms are out of the way. Alright, so I recommend that whenever you're shooting the KUB, that you have the patient, you know, if they're covered, if you got a sheet or a blanket over them, go ahead and get their arms out from underneath the covers. Because in a lot of cases, what happens is you get them all positioned, you get their arms down to their side, you disappear out of the room, and they get comfortable. And when they get comfortable, they're gonna, you know, put their hands across their chest or whatever. You make your exposure, and their hands are still under the covers, and you don't know that they're across their abdomen until it comes up on your screen. Had that happen? We had shouldn't tell the story. I'm gonna step off, make sure I'm out of the camera. But, we had a psych patient that came up from, Rusk to Jacksonville, who was just a little spiteful, as psych patients may be sometimes. And they had, I think she swallowed the batteries. This tells you how long ago it was. I think she swallowed batteries out of her Walkman, right? So before iPods, which aren't even a thing anymore, are they?
Mm-mm.
Yeah. So the technology at the time was to put a CD in this thing that was about 6 square inches, and it was relatively thin. And you had headphones. It weren't even wireless earbuds at that point. And psych patients would want to get out of the psych ward. They'd take the batteries out. 5 AA batteries these things would hold, and they'd swallow these batteries. And they'd make a trip to the hospital. And I'm trying to remember her name. She was a great student. Real quiet. Didn't say much. And I happened to be clinical coordinator at the time, and I was in Jacksonville, and she came out infuriated from the x-ray room. And she was just, I don't remember if she was cussing or not, but she was trying hard not to if she wasn't. So anyway, she comes out of the room, and you know, I said, what's the matter? Well, it was right beside the processor. So what's the matter? So she showed me the x-ray. And this patient, who she pulled out all of her patient care skills for, and honey and babied this person, get their arms down, make the x-ray, and what she did was, as soon as the student went back to make the exposure, not only put their hands across their abdomen, but there was only one finger on each hand showing. Yeah. So who's at Christus? Okay, so she works at Christus now. Oh, I'll think of her name as soon as y'all leave. But anyway, she works at Christus now. Ask around, and you'll hear the
Did you
story.
get booked off?
But it was pretty hilarious. So I recommend that you get your arms out from under the covers because, you know, most of the time it's benign. You know, people just get comfortable, but sometimes it's not benign. People just being ugly. Slightly abduct to make sure that you don't have any soft tissue overlap, and then we'll take a look at each one of those individually. All right, so centering is at the crest, unless you're shooting upright, and then it's going to be above the crest, top of the image receptor at the axilla, which seems kind of high, but it's really not. Top of the image receptor at the axilla for upright chest, or upright abdomen. So most of the time, if we have some sort of pathology, our change is going to be 30 to 50% change. So what pathologies might we see in the abdomen? Edema, ascites. We may have a patient who looks like they're edematous, but they're just swollen, right? We talked about that, I think, last week. If you have a patient that you walk into the room, they've got an NG tube, it's hooked up to suction, and you got bile in the canister, most of the time, that's gonna be air. Okay, so they got this great big distended abdomen, and chances are that's gonna be air. So in those cases, your technique is not going to increase, you may actually decrease. Again, your technique change is gonna be 30 to 50%. I think also I mentioned last week that our cadaver films. If you ever have to go shoot a cadaver, then you need to increase your technique because the fluid will settle in the abdomen and the chest X-ray and the great vessels in the abdomen and chest X-ray. So you need to increase your technique. If you're using KVP, then it'd be 5 to 8% change. So what do we want to include? Idealistically, we would love to see from the diaphragm all the way down to the symphysis pubis. In most patients, you're not going to see all that. Most of your patients, you're not going to see the diaphragm. Probably not going to see the top of the left kidney. And that's why some of your radiologists want you to shoot on inspiration to push all that down to see more of it. So again, follow hospital protocol. So positioning areas we're going to get to, motion, use as short an exposure time as possible. And then rotation, what we're going to look at is we're going to look at the ribs, the pelvis, the iliac wings, sacrum, and then if we have scoliosis, you just can't get around it. So, here's the skeleton. Not tip over the skeleton. From chest X-rays, this should be, kind of a review. So if you have a patient who is rotated, let's say you're shooting AP KUB, and they're rotated with left side down, notice everything that changes, right? So the ribs on the elevated side are going to be more superimposed. Ribs on the side closest to the image receptor are going to be, they're going to appear elongated. I think some of your textbooks really even call it elongation. It's not really elongation. You haven't made them look more, you made them look longer, but they're not truly, magnified in that respect. So the side closest to the image receptor, the ribs appear longer. The side furthest away from the image receptor, the ribs appear, more superimposed. The iliac crest on the side closest to the image receptor becomes more parallel with the image receptor, right? Can everybody see? And the elevated side is more perpendicular, right? Also, you can look at the vertebra. So you've got the body of the vertebra, and you've got the spinous process, which should appear right in the middle of the vertebra, right in the middle of the spinal column. So as you rotate up, what's going to happen is the vertebra is going to go in one direction, and the spinous process is going to go in an opposite direction. And then eventually, if they're rotated enough, you start to see the Scotty dot. Very good, right? So, so that's all of your rotations. Most of the time, you're not going to have a whole lot of an issue with mid-coronal plane tilt towards or away from the image receptor unless you're doing upright, which presents a problem. If you're doing an upright in a bed, what are you looking for? What?
Upright for an abdomen?
Yeah, upright abdomen. Airflow levels, right. So the purpose for getting the patient upright or setting the bed up is so that you can see air fluid levels, right? But how far up does a hospital bed go? And your ER stretchers, they'll go pretty close to 90 degrees, right? But your hospital beds tend to not, right? And they go up pretty good distance, but they don't go up to 90 degrees. So in order to get those air fluid levels, accurately represent those air fluid levels, what do you need? Horizontal central ray, exactly. So where then we have a patient who's in one of those beds who's, doesn't set up all the way, what's your abdomen going to look like? It's going to look horrific, right? So how could you overcome some of that? How could you get the patient more upright if the bed won't get upright? Sponges, pillows, something like that. If they're in a hospital bed, You got a patient in a ER stretcher, you've got more flexibility. All right, so first off, your patients aren't going to want to sit all the way up. You know, your patients are. I'll be honest with you, I can't touch my toes. I used to have that flexibility. I don't have that flexibility anymore. So you set me up at 90 degrees and I'm in pain. Okay, so if let's say the patient's leaning back like this on a hospital stretcher, are you going to get an ugly upright abdomen? Answer is yeah. It's going to be really nasty, ugly. Okay, but what you can do on a hospital stretcher is you can elevate the stretcher as much as possible, right? So you bring the entire height of the stretcher up, and then you look down at the deflation pedals, and what do you see? You see two, right? One for the head and one for the foot. So what you can do is, you know, the patient's up like this, so you elevate them all the way up, and then you drop the foot of the bed, right? So they're not at a 90-degree angle. It doesn't hurt so much, right? You just elevate them and you drop the foot of the bed. Unfortunately, that's not a possibility in a patient's room, so you may just have to use the sponges, the sheets, not sheets, but pillows, whatever it is, to get the patient upright as much as possible. Okay, so I said all that. Horizontal central ray, right? Now when you go home, you should still have your marrows, you know, your second volume of marrows. You remember the coconuts in it? And, okay, so in the skull and sinuses portion, there are 3 images of coconuts. So coconut, you know, has coconut milk inside of it. They shot one with a horizontal central ray, beautiful air fluid level. Then they shot one at a 45-degree angle. Guess what you could still see? Air fluid level, right? Then they shot one perpendicular into the, was it a perfect air fluid level? The answer is no. But you could see air fluid level. And then they shot one that was, you know, just vertical directly into the coconut. You couldn't see anything. So, is it going to, let's say you've got the patient upright as much as possible, but they're still at an angle about like that. Is it going to be that detrimental to the image to put maybe a 10-degree caudal angulation on it? The answer is no. It really is not. For textbook purposes, what do you have to have? Horizontal central ray. Right? For testing purposes, horizontal central ray. For practical sense, at 10 degrees, probably not. It's going to be a better image than the patient leaning back too far. Okay? I've tried it both ways, and the angulation provided a much better image. So pathologies, we've got free air. How do we see free air? Upright abdomen. Make sure you center high enough to get the diaphragms. If you're doing a 3-view abdominal series, you know, that would be a PA chest x-ray or AP chest x-ray, flat and upright abdomen. You should be able to see that free air on the chest x-ray. Back when we used screens and films, it was a much better view on the upright chest x-ray than what it was on the upright abdomen. Okay, spoiler alert, not really spoiler alert, on the test, I think the question on the test on this, I forget exactly what the wording is. I forget exactly what the wording is, but the answer is upright chest x-ray, okay, for free air. You can see it on free air. So if I don't edit the test between now and then, and you see, you know, upright chest x-ray to visualize free air under the diaphragm, that's a legitimate answer, okay? All right. And look at it. All right, so free air, air fluid level, edema. How do you tell edema versus not edema? You know, the patient's normal anatomy. Yeah. Yeah, so you walk into the patient's room, and if they've got a like a respirator on, you know, some sort of mask on, most of the time that's all you got to look at. if they've got a mask on and those straps are just mashed into their face, right? Most of the time, that's gonna be pretty uncomfortable for the patient, but if they're full of water, then their skin kind of takes on a reactiveness, kind of like memory foam, right? So if you've got that, that's a pretty good indication. Look at their ankles. Most of the time, your patient is gonna have medial and lateral malleolus that you can see. Some patients don't. My brother had cankles. You couldn't see them. But what you can do then is to gently press on the patient's ankles, and if the skin bounces back real quick, and not edematous, if it comes back kind of like you mash down on a memory foam mattress, if it comes back very slowly, then they're full of water. Okay. So again, technique correction when you're phototiming. Say you've got a patient on the table, you're phototiming. What's your technique correction for any of that? What's that? Nothing. Exactly. Nothing. Phototimer should take care of it. Very good. All right, so lines we need to watch out for. Feeding tubes, where I talked about. Feeding tubes, you might want to put up on the patient's shoulder. Neonatal central lines are usually going to be a UVC catheter. Feeding tubes, you've got NG tubes, you've got duodenal tubes. So if you're looking for placement of just a regular NG tube, then you're probably going to want to make sure that you get all the way up to the hilum so that you can see whether or not it's in the right main stem. Duodenal tubes, you still need to see that, but you might want to position just a little bit lower to make sure it goes all the way through the stomach and into the duodenum. You can tell the duodenal tubes from the NG tube. The NG tube is just a raw tube, right? It's got a radiopaque strip that goes through it, but the duodenal tubes, like a Dobhoff, it has a weight on the end of it, and the whole weight is radiopaque. So it's a thinner tube, but it's got this big, probably a, 2.5 inch long weight on the end of it. And it should go all the way through the stomach into the duodenum. So we already talked about all that. Assessment, we didn't get all the way down to the symphysis pubis. Would you reshoot an entire abdomen for this? No, what would you do?
Bring it down and overlap.
Just a bladder shot. Just a 10 by 12 bladder shot. If you had to, to make sure that you included the symphysis pubis. So the psoas muscles, patient's really kind of full of feces, so we don't really see much of anything in here except for bony structures and what is not bony structure. So, excuse me. So spinous process in the center, we have symmetry. So aside from that 1/8 of an inch of the lower portion of the abdominal pelvic cavity, that's good. So what do we got going on here? Well, it says motion. We got motion. So involuntary motion, voluntary motion. You can split hairs on patients who cannot be still, being voluntary versus involuntary motion, respiration, and all that. But really, you want to use the shortest exposure times that you can to limit the possibility of either type of motion. So that's just fuzzy. Okay, so what do we have going on here? What's your patient demographic to start with? Young, right? So what did you not include? Symphysis pubis, right? So just like the one we looked at before, would you reshoot this whole thing just to get, the last 1/2 inch? And answer is no. You know, you might even ask the doctor, do you see what you need to see before you go back and reshoot even a bladder shot on this patient? And if they say, we've got to, you know, include the symphysis pubis, then you go back, excuse me, I'm losing my voice. You'll go back and just shoot a bladder shot. All right, so what do we have here? Rotation. We're getting some pretty good Scotty dogs here. So which way we're rotating?
Right side down.
Very good. Right side down. Looks like we got a feeding tube there. Okay, so a lot going on with this one. You know, they pretty much position the patient off of the image receptor. At least they collimate it down. We've also got some right side rotation. Also a young patient. This is interesting. You can actually see a growth plate on the top of the iliac crest on this patient. So we've got a lot going on with this one. We've got rotation, we've got mispositioning, we've got, you know, at least we do have collimation. So neonatal patient, probably for this UVC here. Most of the time UVC, you want it to go up. Just like the subclavians, you want to come down, or the IJ sticks, you want to come down to the right atrium. You would want that going upwards. I don't know that they would reposition that. I don't know what they've got going on there. All right, so I'm not going to, you know, kind of re-go through the rotation or anything like that on the upright abdomen. Just positioning hints. Make sure if the patient's able to evenly distribute the feet, the weight on the feet, have the patient stand upright, have the shoulders equidistant from the image receptor, as well as pelvis or the distance from the ASIS. And also, you're probably more likely to get soft tissue of the arms over the lateral portion of the abdomen with the patient upright, just because they're going to, you know, hang their arms down to their side. So slightly abduct the arms. So anatomy included may be radiologist specific. We had a radiologist that did not want you to get the diaphragms on a 3-view abdomen, you know, acute abdominal series, because that free air would show up on the PHS X-ray. All right, so the flat and upright was positioned at the crest. He was out at Athens. He's gone now. Great radiologist, but that was his routine. So make sure you follow the routine. Upright abdomen, you may position at the crest. You may position at the top of the image receptor in the axilla. So the rotation is going to look the same. The one thing that we did not look at before was the position of the sacrum within the inlet and outlet of the pelvis. So as you rotate the patient, the sacrum should be pretty much pointing to the symphysis pubis, right? To the split between the two anterior pelvic bones. So as you rotate, what's going to happen is your anterior pelvic bones are going to go in one direction, and the sacrum is going to go in the opposite direction. Okay? So if you're rotated towards the right-hand side, the sacrum goes to the left. All right? The problem with upright is the position of the pelvis changes and it tilts, and it makes it a little bit more difficult to use the sacrum to assess rotation with the patient upright, but you can use everything else that we talked about before. The appearance of the pelvis, the appearance of the vertebra, all that stuff. Just looks the same. So upright abdomen, what we're looking for is gas patterns. We're looking for air fluid levels, things like that. You should be marking your upright abdomen if you're using the markers with the bubble and the 3 BBs in it. That's adequate. You don't necessarily have to put an upright with it. That tells you that the patient's upright. So if this is upright abdomen, is it good or bad? Well, it really depends. What's the hospital protocol? Does the doctor want to see the diaphragms? I mean, we got a little bit low on the patient, but do we have to have the diaphragms? Depends, what's protocol? If this is textbook positioning, then no, it's not good. We need to make sure that we have the diaphragms. So, your textbook positioning and your testing positioning would be upright abdomen, you need to make sure you see the diaphragms. But, do you see anything else, before I move on? Does it look like air fluid level? It's pretty flat. So do we see what we need to see? And the answer is probably. Again, since this is a kid, you might want to take that to the radiologist, have the radiologist take a look at it. And if what we're looking for is potential bowel obstruction, then it's probably going to be adequate. Okay, so ascites, bowel obstruction, you got small bowel obstruction, megacolon, free air, large bowel obstruction, any of those things. So in some of your bowel obstructions, some of the bowel obstructions are sometimes caused by secondary pathologies in kids, like intussusception might cause bowel obstruction. It's idiopathic in kids. Don't know why it happens. It just happens in kids. And if we can get the kid to the hospital quickly enough, the danger with intussusception, just to remind you of what that is where you've got a telescoping of the bowel, one portion of the bowel into another. And the issue with that is that it can compromise blood flow. And I like to use the analogy of a water hose. You know, if you've got blood supply going through that portion of the bowel, then the blood supply is kind of like water hose, right? And if you pinch off a water hose, you know, you take a water hose, you bend it over itself, and you pinch it off. What happens to the water flow? It stops. So applying that to blood flow, what happens to the blood flow? It stops. And if you've got no blood flow to an organ system, what's going to happen to the organ system? It's going to die, right? So if they can get the patient to the hospital quickly enough and do like barium enema or something like that, gastrographin enema, iodinated contrast, they can decompress that and the patient can go home. In adults, the intussusception can be secondary to cancer, okay? So in kids, the intussusception may be idiopathic, we don't know why it happens. In adults, it's usually secondary to something else. All right, so we've got ascites. This patient has just a really ugly gray image, a hypersthenic patient, and they're full of fluid in addition to. Ascites again, and in this case we've got a patient who's not hypersthenic, but they're also osteoporotic, so it also gives us a very gray image. So small bowel obstruction, very clear air fluid levels in this case. Another small bowel obstruction, could it be mechanical or is it non-obstruct ileus? All a non-obstruct ileus is a paralytic bowel. It can happen because the patient's on pain medication. Post-op, that's a common thing. I may have asked, last week, I don't know. Classes kind of blend together. If you've ever had surgery, then you know that before they'll let you go, they need to, at minimum, hear bowel sounds through a stethoscope. And most likely they're going to want you to have bowel movement or at least pass gas, just to make sure your bowel's moving. So those would be cases of non-obstruct ileus. Mechanical obstruction would be something like an impaction or cancer, something like that. So large bowel obstruction, just more of the same stuff. Megacolon, aganglionic megacolon, little kid, bless his heart, that's got to be painful. So, any questions?